Welcome, everyone. We're excited today to host this webinar on innovations to risk adjustment for Medicare. This should be a very interactive and hopefully informative webinar. We have a really great set of panelists. And I would also like to mention that this work has been very generously sponsored by the Commonwealth Fund, Robert Wood Johnson Foundation, and Smith Futures. I'm Amol Navathe. I'm a professor of medicine and health policy at the University of Pennsylvania, and as well as vice chair of the Medicare Payment Advisory Commission, or MedPAC. I'm very excited about the great group of panelists that we have today. Before we dive into some substance, just wanted to go through some housekeeping items. So we are going to try to keep this webinar as interactive as possible. That includes you. So we would love to have your questions in the Q&A feature of the Zoom chat. Please submit those. Please also, if you have specific panelists that you're directing that to, please indicate that as well. I will incorporate those into our moderated discussion. I also want to note that all participants will be in listen-only mode. Today's presentation is also being recorded. If you would not like to be recorded, you may hang up at this time. And finally, just as a quick heads up, following the presentation and the webinar, you will have an opportunity to give us feedback via survey. This should only take a few minutes, and it helps us incorporate your feedback so we can improve our programming in the future, as we do have events coming through the Parity Center over the course of the year. The webinar will end promptly at 1:30 p.m. Eastern Time. So with that, I would like to introduce the panelists. We are very fortunate to have an amazing group of panelists today. Each of the panelists will speak for 10 minutes, and then we will go into a moderated discussion, and then an audience Q&A through the questions that you'll be submitting. Although if you submit them earlier, I also might pick them up and incorporate them into the moderated discussion itself. Presenting first will be Ravi Parikh. Dr. Parikh is an associate professor in the Department of Hematology and Medical Oncology at Emory University. He will be talking about unfairness and inequity in Medicare's HCC score, and I'll tell you a little bit more about that in just a bit. Next, we have Daniel Schenfeld. He's an adjunct professor of medical ethics and health policy at the University of Pennsylvania. He will be speaking on applications of machine learning methods to risk adjustment to improve prediction, specifically of health spending. Next, we'll have Dr. Austin Kilaru. Dr. Kilaru is an assistant professor of emergency medicine. He's also deputy director of the Parity Center at the University of Pennsylvania. He'll be discussing social risk adjustment and developments in that space. And then last, but certainly not least, we have Dr. Karen Joint-Maddox. Dr. Joint-Maddox is the co-director of the Center for Advancing Health Services, Policy, and Economics Research at the Washington University in St. Louis. She will be giving reflections upon the three presentations before her and really helping us distill what some of the key policy insights are. So before I turn it over to Ravi to start us off, I wanted to give a brief introduction about why we're having this webinar and why we're studying risk adjustment in the first place. Risk adjustment is a foundational element of our payment system. It's important to safeguarding our system from selection, for example, of favorable patients or avoiding unfavorable patients from a payment perspective, and preventing adverse incentives. Yet at the same time, it's a very complex subject, and it's absolutely a subject of intense debate. On one hand, it can get technical and wonky, but our goal here is to bring that kind of technical, wonky subject and really elucidate how it impacts the real world. Fundamentally, it impacts real patient lives. We're going to focus today on the HCC score used by Medicare, which is the Hierarchical Conditions Classification System. There are multiple ones of these, and we're going to focus on the one called the CMS-HCC score. Now, the CMS-HCC score and risk adjustment generally are definitely not perfect. In work that we've done as part of my role at MedPAC has found that there's evidence of favorable selection, as well as responses to these incentives via greater intensity of coding. Risk adjustment, again, is still a foundation of our system. So fundamentally important to see how we can improve this. And alongside that, over the past decade, we've seen great advances in the science of algorithmic fairness and data science that help us gain a deeper understanding of how these algorithms that are functioning, these risk adjustment models, how they're functioning, and what the relationship is between risk and the underlying data that's used in these models. So with that as a backdrop, let's step into our first panelist, Dr. Ravi Parikh, who will be talking about unfairness and inequity in the HCC score. Dr. Parikh?
Thanks so much, Amal, and thanks to all of you for joining this webinar. So again, I'm Ravi Parikh. A lot of our work, our collective work in collaboration with the Parity Center, focuses on how we make risk adjustment algorithms more fair. So before I advance my slides, I just want to take a couple of minutes and talk about algorithmic fairness and what we mean when we say that. So any risk adjustment algorithm is based on a predictive algorithm in large part. And getting algorithms to predict follows a relatively straightforward playbook. You train a model, you validate it on traditional performance metrics that reflect primarily the accuracy of that model. And that accuracy is usually quantified by statistical metrics. By note, the advent of machine learning methods and more advanced predictive models have facilitated remarkable increases in accuracy for predictive algorithms. In this case, the ability to predict an outcome like how much an individual will cost in the forthcoming year. By being able to incorporate and model linear and nonlinear relationships between lots of different covariates. But equally important in the context of risk adjustment to accuracy is fairness, the process of ensuring that algorithms and their outcomes are unbiased and don't discriminate against individuals or groups based on sensitive attributes like one's race, gender, or age, or other protected features. Now, we've known for some time now that decisions that are based on algorithms can be systematically biased against certain individuals. And we don't have to necessarily constrain ourselves to healthcare to just realize this. For example, if you've ever read about facial recognition technology, the type of technology that opens your iPhone or that's used in criminal justice applications, there's been a well-publicized literature that facial recognition technology often mischaracterizes faces for Black and brown individuals compared to white individuals, oftentimes leading to well-publicized cases of misidentifying and unfairly criminalizing certain individuals for crimes that they did not commit, which is a hugely important and unfortunate problem. But applications of unfairness also apply to other important algorithmic features. For example, algorithms that are used to distribute loans for credit, for example, or that are used in the judicial system. So these are just examples of how the algorithm fairness literature is not necessarily constrained to healthcare, and in fact has probably been better characterized in areas outside of healthcare. Now, one thing about fairness, though, is that fairness cannot be measured purely by statistical metrics. Fairness often depends on how an algorithm is deployed. For example, are we using an algorithm to dictate a certain intervention, like a care management program, for which an individual might exceed a certain risk threshold and then receive an intervention? That typical decision support tool, we might think about certain metrics of fairness that could be different from algorithms that are used to, say, risk adjust payments across all areas of the risk spectrum, not just whether they exceed a threshold or not. So enter in the healthcare context, and specifically the risk adjustment context and risk standardization context used by Medicare. Now, it's been well characterized in certain studies, for example, a seminal study by Obermeyer and colleagues, that using spending as an algorithm to predict for your risk adjustment algorithms may unfairly bias against certain individuals, most notably Black individuals, because at a similar level of clinical risk due to access issues and other issues related to systemic racism, Black individuals may cost less than white individuals. And when we use cost or spending as a proxy for clinical risk, that can be potentially an issue if you're allocating resources based on clinical risk. Interpretations of fairness also depend on understanding the base case of disparities. For example, in Medicare risk adjustment, a purported goal is to allocate preferentially more resources to Black and Brown individuals or hospitals serving them to rectify for historic disparities. So we need to think about that when we talk about making algorithms more fair. So enter in Medicare risk adjustment algorithms, and we can advance the slides now. I'm going to highlight some evidence from work that we've done with two algorithms used by Medicare. One are risk standardized mortality rates, and the other are the aforementioned hierarchical conditions categories, or HCC score. So talking about the RSMR first, these are condition-specific measures of, in this case, we study 30-day mortality after a hospital discharge. These are often publicly reported and used to judge the quality of hospitals and used to determine payment and pay for performance programs. And you can see some examples of the type of programs in Medicare that use the risk standardized mortality rate, which standardizes the observed mortality rate by a hospital based on a predictive algorithm. The hierarchical conditions category score is a different risk adjustment algorithm that's used to risk adjust payments for at least 65 million Americans in certain plans like Medicare Advantage, accountable care organizations, and Affordable Care Act health exchanges. And you'll hear a little bit more about the details behind the HCC score in subsequent presentations. So let me walk you through a little bit of data that we've used to expose unfairness in each of these scores. So in the next slide, we study the core research question of what may cause unfairness by race in a particular risk standardized mortality rate for patients with heart failure. And I'll just note that these examples I'm going to share you generalize across other clinical conditions as well. And so the upshot here is that we find that one particular variable in the RSMR, notably age, because there's differential distributions between Black and white individuals, leads Medicare to overestimate the quality of hospitals that serve predominantly Black beneficiaries. So let me show you how we get there. We can advance one panel here. And so what we can see at first, when we look at just one of these important variables, age, we can see that there's very different distributions of age. In this panel, where Black individuals are reflected in orange and white individuals are reflected in blue, we can see that age is typically left shifted, meaning that Black individuals among the inpatient, among hospitalized patients tend to be younger. What does that lead to? As we can see in the next panel, when we study the association between age and mortality, if we could just advance the slides here, we can see that at any given age on the x-axis, the mortality rate is different for white and Black individuals. At any given age among the inpatient population, Black individuals tend to die at slightly lower rates than white individuals. So differential age mortality relationships can manifest themselves in the algorithm in different ways. So as we can see in the next panel, when we advance, we can see that on the y-axis here, we see excess prediction, meaning how much does the RSMR risk prediction algorithm over-predict risk for certain categories. And we can see that it tends to over-predict risk, meaning that the numbers are greater than 0 for Black individuals compared to white individuals, which can manifest itself in the way that this program is implemented, as we can see in the last slide. We can see when we account for these differential age mortality relationships, the percentage of hospitals that would be characterized as lower quality really increases as we get to more non-white proportions in those hospitals. Essentially, in translating that, that means that because of these differential age mortality relationships, we overestimate the quality and may unintentionally be reassured at quality of hospitals that serve predominantly Black and Brown individuals. Let's take a different algorithm. So if we can go on to the next slide, let's study the HCC score, which, as mentioned, is used to risk adjust payments to Medicare by Medicare in programs like Medicare Advantage. So in this study, we analyzed whether spending is potentially a biased outcome for rural dwelling Medicare beneficiaries. So as you can see in the first panel here, where we look at the spending outcome, we can see in general we used a 5% random sample of Medicare beneficiaries. In the fee-for-service population, among both dual eligible and non-dual eligible populations, that in general, the HCC overpredicts spending. How do I get that? Well, you can see on the y-axis here, rates of observed versus predicted spending from the HCC score. And in general, all of the lines here are below 1, meaning that in general, patients spend less than predicted by the HCC, particularly at higher values of higher predicted risk thresholds. But you can see that the blue line here, indicating rural beneficiaries, is generally lower than the red line, indicating that we overpredict spending, particularly for rural beneficiaries. However, when we use a different metric of risk, as you can see in the next panel, if you click ahead, mortality, a measure of clinical risk, we tend to underestimate mortality for rural beneficiaries compared to urban beneficiaries, where we generally get it around the dotted line. So what does this mean? It means that algorithms that try to risk adjust based on predicted spending may underestimate risk for certain groups of individuals, particularly rural beneficiaries here, where we see that mortality, as predicted by the HCC score, is way in excess of what's predicted. And that may mean that we're under-allocating certain resources based on an actual clinical metric of risk. So hopefully these two examples here have shown some examples of unfairness across two commonly used risk standardization and risk adjustment algorithms, and excited for the Q&A.
Great. Thank you, Ravi, for that incredibly fascinating presentation. So I have many, many questions for you, and I'm sure the audience will too. Just for keeping this efficient, however, we're going to hold our questions right now, move forward to the next presentation, and that is Daniel Schenfeld. So Daniel, will turn it over to you to lead us through your presentation.
Yeah, thanks, Amal, and thanks, Ravi, for a great presentation. I'm going to talk about applications of machine learning for risk adjustment. No need to worry, there's not going to be anything overly technical. The main questions that we're going to address is, can we use machine learning to build more accurate risk adjustment models? How might we go about doing that, and what would be the implications of more accurate risk adjustment, and specifically risk adjustment models that are built using machine learning? Can we have the next slide, please? So to start, I'd like to talk a little bit more about the HCC model, which, as Ravi mentioned, is the primary risk adjustment model used by CMS to risk adjust payments primarily to Medicare Advantage plans as well as others. So Medicare Advantage currently covers about 35 million Medicare beneficiaries, representing over 50% of the Medicare population. And the way CMS pays Medicare Advantage plans is a capitated risk adjusted amount. This means that each beneficiary that's enrolled in an MA plan gets a risk score. That risk score can be anywhere from 0 to a very high number like 10. And that number is multiplied by a base amount, which is roughly $13,000 for last year, 2024. And what that means is that the risk score immediately is reflected in payments to MA plans. We're talking here about $800 billion annually, if I remember correctly, so a significant amount of money. The second point that's relevant here is that a risk adjustment algorithm is essentially a cost predictor. So what CMS is trying to do is they're looking at a particular beneficiary. They only use age, gender, and ICD codes, so their diagnosis codes, to predict what is going to be their spend next year based on the diagnosis codes that are recorded this year. And that cost prediction is essentially their HCC score, which translates directly to payment. The way the HCC algorithm works is very simple and very intuitive, and also rather old. So HCC was developed about 20 years ago in 2004 and has periodically been adjusted since then. The current version of HCC, which was rolled out 2 years ago, it's called version 28. What it does is the following thing. It looks at all the ICD codes that Medicare beneficiary has and assigns them to a hierarchy of 115 categories. So a category could be something like diabetes, CHF, COPD. There are some very broad categories, including most kinds of solid tumors. So these categories are pretty broad. And then each category is assigned a weight. And so if you have any particular ICD that maps, for example, to a CHF category, you'll get assigned the weight of CHF. And then those weights are summed up. There's not a lot of relations or interactions between the various categories. In that sense, they don't really capture our clinical intuition of what it means to be, for example, a complex polychronic patient. We just sum up those weights. And as a result, the HCC cost predictor is highly inaccurate. We'll talk about some specific metrics in the next slide. But just to drive home how much inaccurate HCC is, we observe in non-dual beneficiaries that about half of all bennies don't have an ICD that maps to any ICD code. That means that the risk adjusted based on age and gender alone. And as you can imagine, there is a wide variation of cost among these half of Medicare beneficiaries, but the MA plan will get very similar amounts for each of these members. Another 25% or so have only one HCC category assigned to them. And so while those are a little bit slightly less inaccurate, still it only captures one condition that person may have. So hopefully that gives a sense of both the rigidity of the HCC model and why it is so inaccurate. That raises the question of, well, can we do better? Can we build a more accurate model? And with that, can we have the next slide, please? So one way to do that is to use what's called machine learning, which in this context means two things. It means that we're going to take a data-driven approach as opposed to an expert-driven approach. The HCC hierarchy was curated by experts, both clinicians, people with a background in medical economics, and they decided how to create the hierarchy. However, there are 70,000 ICD codes or so, and so you can imagine that if people were trying to create a more granular hierarchy with, let's say, thousands of categories, that would be beyond what a human can do. With machine learning, we can create a much more granular hierarchy. And another thing that we can do is, rather than very rigidly, deterministically assign each ICD to a single category, to be able to capture how an ICD may modulate different disease conditions. So that's one aspect of using machine learning. Another one is to capture many more of the complex interdependencies between diagnosis codes in an attempt to more closely represent the actual clinical profile of a particular beneficiary. As I mentioned earlier, in HCC, we just sum up the contributions of each, for example, chronic disease, which doesn't really allow us to distinguish how much more complex a polychronic patient is than someone with just one chronic condition. Our group at Penn, which Ravi was also part of, has worked for a while on building a new machine learning model. We call it Franklin, and after Ben Franklin, the founder of the university. And to get a sense of how much more accurate Franklin is than HCC, we can look at the graph on the right. So the bold blue line, the outline, represents the actual cost distribution of Medicare beneficiaries. And as you can see here, HCC captures that distribution very poorly. In particular, almost nobody on the lower end of the distribution is accurately captured. Franklin, which allows assignments of ICDs to multiple data-driven categories and allows fractional assignments, is able to capture the distribution much, much more closely, especially at the lower end of the distribution. The high end of the distribution in general is expected to be very difficult to capture because these are beneficiaries whose costs are driven primarily by inpatient admissions and sometimes post-acute care. And those are essentially impossible to predict just based on diagnosis. As you imagine, the same two patients may have the same diagnosis codes, but only one of them may get admitted in a given year. So hopefully that gives a sense of how much more accurate we can get with machine learning. Let's discuss in the minute or so that we have remaining the implications. Can we have the next slide? So traditionally, risk adjustment models focus on identifying high spenders to prevent underpayment to MA plans. This is what HCC is trying to do. We're trying to give MA plans incentives to participate in the market. However, as Ravi and Amol mentioned before, we know that there's a lot of overpayment in MA. And overpayment comes from the low-cost members that are overpaid. And so it's very important for a more accurate risk model to correctly identify who's likely to be a low-cost member. In terms of the actual impact, a more accurate risk adjustment model would more accurately, the flow of payments would be more accurate. So cheaper patients would get compensated less, and more expensive patients would get compensated more. But it wouldn't necessarily change the total amount of funds that CMS pays MA plans. For that, we would need some additional policy changes. I'll stop here. I'm looking forward to the Q&A and discussion. Thank you.
Thank you so much, Daniel, for a great presentation. Super eye-opening, I think a lot for us to think about. So let's move now to the third presentation, Dr. Austin Killaroo, who's going to transition a little bit from a topical perspective and get a little bit more into this concept of social risk adjustment using area level measures as opposed to how to optimize on the individual piece of the risk adjustment. So Austin, let me turn it over to you.
Hi, everyone. Appreciate the opportunity to chat with you all today. So as Amol mentioned, my fellow panelists have discussed some of the problems with our current risk adjustment methods, particularly the CMS-HCC algorithm. And I think they presented really compelling evidence that the algorithm may be unfair for certain populations and that it may lead to overpayment due to certain inaccuracies. And I'm going to ask a related but slightly different question, and we can advance the slide. So the question I want to address is risk adjustment based on clinical factors enough? So even if we were to optimize the CMS-HCC algorithm or some other kind of approach, are there other factors that we should be considering in our overall strategy and approach to risk adjustment? My colleague at Penn, Aaron Schwartz, recently published a commentary in Health Affairs that I highly recommend. And he wrote that risk adjustment policy is a single policy tool with multiple different goals. And he used the analogy of Robin Hood shooting multiple arrows at once, where each arrow is hitting a different target, which I felt was a good analogy. And among those goals is the need to prevent overpayment. But another goal, and another important goal, is equity. Specifically, how can we use risk adjustment to allocate the appropriate healthcare resources to the patients and providers that need them the most? And we know that social determinants are major drivers of health outcomes. In a value-based payment model, like an ACO or bundled payment program, if we do not fully account for those social needs or those social determinants in a risk adjustment approach, then we're placing greater financial risk on the providers that care for patients with those greater social needs. And there's some circumstantial evidence that this has occurred in value-based payment. We've seen in voluntary ACOs and bundle payments that participation is less among safety net providers. Essentially, safety net providers are not joining these programs at the same rates as other providers. And we've also seen that in those models, that safety net providers have incurred disproportionate penalties for the outcomes in models like CJR, Comprehensive Joint Replacement Model. And I think the concern here is that the innovations in care that we would expect from value-based payment would not be accessible to patients with high social needs because providers are not participating in those models. And that's taking away the chance for those care innovations to improve quality, potentially a disproportionate amount. So the CMS Innovation Center has actually already acted to address this. So in a variety of different payment models, they've implemented different mechanisms to perform social risk adjustment. And this concept of social risk adjustment is really defined as what can we do in addition to clinical risk adjustment to modify payments based on the social needs of participants. And that's a way of encouraging safety net participation and avoiding disproportionate penalties. Again, examples of this and the methodologies are different, but there is some component of social risk adjustment in different models like ACO REACH, the AHEAD model, which is a state-based model, and a future bundle payment model called TEAM, which is expected to launch next year. So our team wanted to find more direct evidence for whether this social risk adjustment, this additional social risk adjustment, is actually necessary. Again, CMS believes that it is, but there is actually some evidence that social risk adjustment might not add that much. So we can move to the next slide. Now, the way that CMS has performed social risk adjustment has been to use area-level measures of neighborhood disadvantage. And the idea here is that Medicare does not have detailed person-level data on social needs. So we can use area-level measures as a proxy. The most common of these measures is something called the Area Deprivation Index, or the ADI. And this is a composite measure of social disadvantage that's based on 17 different factors. And it provides a measure of social or economic advantage, disadvantage at a very small level, at the 9-digit zip code, which usually contains about 4,000 people. I'm showing here a map of ADI for the city of Philadelphia and the surrounding area. So at a high level, our approach in trying to provide some more direct evidence on the need for social risk adjustment was to first predict outcomes for patients based on the CMS-HCC algorithm, the clinical risk adjustment algorithm, and use that algorithm to predict outcomes like mortality and spending. Then we wanted to determine whether there was an additional association of those outcomes with the area deprivation index, meaning that could the ADI, or area deprivation index, account for any mortality or spending in excess of that predicted by HCC alone. I also want to note here that most analysis of risk adjustment examine spending as an outcome, but we also wanted to include a clinical outcome like mortality because spending is a function of healthcare access, and we wanted to look at the direct effect of social disadvantage on health outcomes for a population, not just spending. So again, the question is neighborhood disadvantage associated with excess mortality or spending after accounting for clinical risk adjustment? We can move to the next slide. So the short answer is yes, it appears to be. So looking at the plot on the left here, we found that the areas, the 9-digit zip codes with the highest ADI, meaning the most disadvantaged, that there is higher excess mortality, meaning that the observed mortality is higher than we would predict by HCC alone for those more disadvantaged areas. And we found actually the converse is also true. The areas with the lowest ADI on the left side of that plot, there is actually less excess mortality. It's almost a dose-dependent increase in the excess mortality based on how you increase ADI. On the right here, we found the same association with excess spending. So again, the areas with the highest excess spending, the areas with the highest disadvantage have the highest excess spending. The spending is in excess of that predicted by HCC alone. So I think we're still in the early stages of answering these questions and seeing what exactly social risk adjustment might do to change incentives within payment models. But we have some evidence to suggest that there is an empirical basis for social risk adjustment, meaning that we could use risk adjustment based on social factors to more appropriately allocate resources to the patients and providers that are predicted to have worse clinical outcomes. So how can we change payments to allocate those resources to patients in the highest areas of ADI and the greatest financial risk with those areas have the highest spending, again, to both increase participation in these payment models among providers that care for those populations, but also to ensure that within those payment models that those organizations do not incur higher penalties because of the social needs of their participants. So looking forward to the discussion and answering questions. Thanks.
Great. Thank you so much, Dr. Kilaru. So welcome, Dr. Joint Maddox. So what we've asked Dr. Joint Maddox to do is reflect upon these three presentations. You know, these are research work streams that are independent from one another, but they're all thematically aligned, and no person better than Dr. Joint Maddox to actually tie it together and give us a sense of what this means for policymaking, what this means for risk adjustment going forward. So Karen, we'll turn it over to you here.
Thank you so much. And those were wonderful presentations and certainly a lot of food for thought. And I'll hope to probably tee up more questions than answers and hope that we can spend the rest of the time having a discussion about some of the nuance in all that we've seen today. So next slide, please. So I will mention this at the beginning, but I think it's reasonable to sort of, think again now as we've seen these presentations, why do we risk adjust? On the payment side, it's really to think about ensuring fair compensation for insurers, right? We want to avoid setting up these adverse incentives for caring for high-risk beneficiaries. If we paid the same amount for everybody, sort of taking it to its extreme, there would be an intense disincentive to taking care of anyone who would be high cost. We want to ensure equity among plans, again, focusing on costs for a moment, to avoid advantaging plans that attract the healthiest patients. So if it's not perhaps because you've gone and sought those patients, but however folks sort, we don't want to disproportionately advantage plans that have the healthiest patients or penalize those with the least healthy. We want to prevent under and overpayment to try to make the system work as effectively and efficiently as possible. And I think we also want to incentivize accurate reporting of health conditions, which is obviously a double-edged sword. You can imagine that there's been as much talk as there has been about overcoding or upcoding in Medicare Advantage. There is concern about undercoding in fee-for-service, where there's less of an incentive to capture health conditions. And since the risk models that we use base their betas or sort of the way that they work on accurate collection of comorbidities, not just from Medicare Advantage, but also from fee-for-service, in fact, based on fee-for-service, there is some incentive to be able to capture those clinical conditions in both the Medicare Advantage and fee-for-service side. When you think about risk adjustment for clinical conditions, it's a similar list, right? So fair judgment across providers and value-based payment programs, for example, preventing over or under reward, if you're thinking about how those programs may respond to the performance that's calculated based on these risk models. So next slide, please. So unfortunately, I think the data that we've seen today suggests that we're getting it wrong, and that's in two ways, so technically and strategically. And I'm going to try to separate out those two things because I think they're actually probably worth separate consideration. So we're systematically over-predicting costs. If you look at the machine learning slide, right, we're mispredicting, especially in those low-cost folks. But among the most disadvantaged, we're under-predicting costs. We're over-predicting costs in some groups because they have more access. We're under-predicting in others because they have less access. We mispredict clinical outcomes. You heard about over-predicting mortality for Black beneficiaries compared to white. We under-predict readmissions for Black beneficiaries compared to white, right? So there are factors at play in determining health that are not captured in the things that we are using. And consequently, we essentially have a suboptimal system, both for cost and for outcomes, in trying to hold providers accountable or in trying to sort of fairly allocate resources. So next slide, please. I think we should think about, in addition to the technical fixes, how we could use risk adjustment more strategically. So you could make actually decisions about how to err. So in which way would you like to make your mistake? Should we overpay or at least not underpay for high-risk patients that need additional services that aren't captured in fee-for-service billing? So if we think that what it takes to keep heart failure patients out of the hospital is that we provide care coordination services that aren't currently billed for, we suspect that their predicted costs do not actually reflect what needs to be spent, then we should overpay. Should we overpay or at least not underpay for beneficiaries that have been historically marginalized and denied access to services sort of across the life course in order to try to correct some of those wrongs? Does overpayment reward high quality care for those complex patient populations? Or does it just give people a free pass, right? If not coupled with appropriate incentives to make sure that those patients are doing better based on better health and not just less utilization, you may be overpaying with no return, which would be worst case scenario. There's also both over and underutilization that we need to think about strategically. So the lack of access distorts spending among the socially vulnerable, right? So spending is inappropriately low because there is unmet need. The flip side is actually also true. So too much access, whatever that means, distorts in the opposite direction. So if you're overusing MRIs for back pain or something like that, you actually bake that overutilization into risk adjustment in association with whatever the factors are that you're measuring. And because we don't necessarily think about the type of costs that people are incurring when we build these models, those distortions become sort of part of the model, particularly in something as oversimplified as the current HCC score. We, of course, need to think about upcoding. Now, you could combat upcoding as a sort of a strategic approach, either by having very simple or very complex algorithms. If you have a very simple set of algorithms, such that a bunch of additional coding doesn't get you much, that would sort of definitionally prevent upcoding. On the other hand, you could have something like a machine learning model where it's actually not quite clear that adding a certain diagnosis is going to get you X more dollars, which could also reduce at least intentional upcoding in a way that would be considered gaming. We'll never get away from gaming, but it would at least make it a little bit less obvious how to go about that. Next slide, please. So what are some simple-ish near-term fixes? And I hope we can discuss other ideas as well. I think the most straightforward is to try to fix the obvious mispredictions. We did some work 10 years ago now. We're simply adding frailty, disability, cognitive and mental health, and other more holistic markers to the existing risk models, made them much better predictive, especially for things like readmission, where holistic health and not just sort of the acuity of disease matters. There's no particular reason that even the current infrastructure of the HCC technical model couldn't absorb a more holistic set of risks. If you look at the risk models for things like risk standardized mortality, they're even simpler. That was like some cardiologists sitting down in a room saying what mattered for mortality for heart attacks, and they turn out to have gotten it pretty wrong. It's not really about whether, sort of the size of your heart attack, though that certainly matters. What matters a lot more are things that are not in those models. Like, have you had a pressure ulcer? Do you have bad enough diabetes that you've had an amputation? Sort of things that are much more holistic. Do you use a wheelchair? Are you on oxygen? And those things are not included in most of these models because, as Daniel mentioned, they were expert-driven rather than data-driven. I sincerely believe that we can level up to better models. Now that can require some additional work, but we really are in a very different technological moment than we were when most of these things were created, and they can handle both sort of more data as well as more interactions between data that I think could, data points that I think could allow us to be more accurate. I think we need to decouple spending prediction and clinical risk prediction. One's about budget, one's about equity and access, and the relationships don't necessarily go the same way. And we need to think strategically about error in those two things differently than we do now. And I think we need to open ourselves to the possibility of including social factors to the degree that they do impact costs or mortality. I personally feel that including them at the individual level where feasible is probably the most accurate way to do it, but to the degree that that area level information adds additional accuracy, which it certainly was shown to in Austin's presentation, those can be really important to to resource allocation as well. So I throw that out there, again, not so much to have answers, but to raise more questions. I can see we're already getting some questions in the Q&A, so look forward to a robust discussion, and thanks to all the presenters for wonderful talks to spur us in the right direction.
Fantastic. Thanks so much, Karen, for your comments. So what I was hoping to do, thank you also to the audience, by the way, for submitting the questions to the Q&A. I've been tracking them. So what I'd like to do is invite all the panelists back on camera. And why don't we go through, I think there's a few different areas that we can do a little bit of clarification or recap of each of the specific studies and presentations. And then let's zoom back out at Karen's level and talk about policy implications and what this all means. So let's start with you, Ravi. I just wanted to make sure we kind of get the main message and understanding right here. So checking my own understanding here, Black beneficiaries are younger than white beneficiaries. So that's just a demographic observation that you are putting up there in your slides. And if I understand correctly, one of the findings that you have is that age is less predictive of mortality for Black beneficiaries than white beneficiaries. So those are kind of two important things. And the next step is, because Black beneficiaries are the minority population in the data, then we get this situation where the variables effectively in this HCC model, including age, are utilizing the prediction coefficients for white beneficiaries, essentially for Black beneficiaries as the minority population. And that's where we're getting over prediction of mortality for Blacks. Am I more or less capturing that correctly?
Yeah, absolutely. Happy
Okay.
to expand on that, but yeah, that you've got it.
Great. Okay. So one thing is puzzling at times is, as we've looked at the variety of presentations here, we see that if you take a subgroup, and there's, I think, a great question in the chat as well about subgroup prediction. So I'm going to kind of weave this in here, and then I'm going to bring it back to you, Daniel, as well. So depending on spending and mortality, so what you showed us is it depends on the outcome. When is over prediction versus under prediction good or bad for a marginalized group? Like, how should we think about this? It seems to me that we think of prediction or calibration as these kind of diagnostic elements, these characteristics of these models. But at the same time, it's very puzzling at times. Do you think about prediction of mortality, and it seems like, oh wait, if we over predict mortality for Black beneficiaries, does that mean that that's protective for risk adjustment? Or if we over predict or under predict spending, maybe under prediction of spending is good because we're going to allocate more dollars in Medicare Advantage. So how do we think about this over prediction versus under prediction in the context of these outcomes?
Yeah, well, first I'll just say, I think that the question around subgroup level performance is really important. Anytime you take a subgroup and try to assess performance of an algorithm trained in a general population, you're going to get differences, usually, in performance between one subgroup versus another. I think it's important when we're kind of looking for fairness-related concerns to take a little bit of to anticipate what our priors are here about why we might anticipate differential performance. We know from historical data, forget anything about the HCC score, we know from historical data that Black and brown individuals, condition by condition, oftentimes spend less than white individuals with the same condition because of access issues. And so we take that prior into exploring what's going on with the HCC score in that fact. Otherwise, we might be making a lot out of other subgroup level performance differences that frankly might not matter because of confidence intervals and low sample size and such. So I think that we need to take a little bit of a deterministic framework into this. When it comes to the fairness context and anticipating what's a problem versus not, I think you're totally right, because oftentimes in these conditions, like say if you're using an algorithm for allocation of care resources, it might be a good thing, and you might intentionally want to overpredict for certain subgroups of individuals so that those individuals get more of a certain resource. That might be an intentional way that you design your algorithm. And so subsequently, if you're seeing an unexpected underprediction where high-risk individuals or individuals who are high risk by a well-accepted metric aren't getting the resources that they ought to, then that's a problem. And you ought to be adjusting your algorithm either by trying to account for variables that you feel like more appropriately reflect that risk, for example, social factors, or by changing what you're predicting and using a clinical metric other than spending, for example. But I think it's important to note that overprediction is not always a good thing for subgroups of individuals. And I think our RSMR example speaks to that a little bit. Because even though you might be over predicting mortality in that use case and making hospitals that predominantly serve Black and brown individuals look good, that might be hiding potential quality gaps at those hospitals that should be addressed, that people aren't necessarily attuned to because people are overperforming at a metric, so everything is all said and done. And so I think it's it's important, in short, important to come into this with a little bit of a deterministic framework as to which subgroups we think are going to be marginalized by an algorithm. And it's important to think about how the algorithm is deployed to sort of elucidate whether a subgroup performance difference is truly unfair or not.
Great, so super helpful. So I want to zoom in on the rural subgroup because you also showed some interesting data there. And if I'm understanding correctly, we're getting this situation where HCCs are over predicting spending for rural beneficiaries, but they're under predicting mortality for the same set of beneficiaries. So what does that tell us about the fairness of the HCC score? Is that a flag of concern? I mean, it seems like it's a flag of concern, but help us kind of process what's happening there to produce that kind of result.
Yeah, and so I think this goes back to the thought about why we are even focusing on rural bennies in the first place. So it's similar to the concern that we had for racial minorities in that we think that rural beneficiaries, condition for condition, which is what the HCC score is based on, condition for condition, rural beneficiaries may have lower access to health services, and so at a given condition, predicted risk based on clinical conditions, we see that because of some of those access barriers, our hypothesis is that rural beneficiaries spend less, which is why we tend to overpredict spending. But I think this is very inarguably a much clearer example of potential unfairness, because if we thought of the HCC score as trying to account for clinical risk, then we can clearly see, using a more appropriate clinical metric, that we're under predicting mortality based on the diagnosis codes used in the HCC alone, which means that even though rural beneficiaries are spending less at a given condition, they're dying more. And that, I think, is, in my mind, clearly a function of lack of access to high quality resources in healthcare that is sort of being baked into the algorithm. So it sort of speaks to me that if we were going to try to reform the HCC score in some way, incorporating some of those clinical metrics of risk, either in the outcome or through broader X's, would clearly differentially benefit rural beneficiaries, or at least that would be the hypothesis.
Great, thanks, Ravi. That's super helpful. So Daniel, we see in Ravi's study that predicting spending is potentially challenging for a variety of reasons, right? He mentioned X's as an example. We have spending consideration, access considerations and spending for subgroups. We have the Obermeyer paper that Ravi mentioned that says, spending may not be the best outcome in some sense for predicting risk in particular. Now you've taken the existing, as I understand it, kind of the existing infrastructure of what goes into the spending predictor for CMS-HCC, and you've said, okay, let's hold that constant and let's use better methods, or at least more advanced methods that will allow for more flexibility in terms of things like interactive effects and other elements there. So what I wanted to ask you here is kind of a two-part question. One is a question that I was thinking about, and another is a second question that's come through the chat, which is from Bruce Bunyan. And we're going to I'm going to adapt his question a little bit to kind of fit it into what I'm trying to ask here. So number one, I think I just wanted to understand here, why is it that Franklin is doing in particular better on the lower spending side of the predict of this of the distribution of beneficiary spending. And then the second piece here is Bruce's question basically touches on this point of, is the problem basically that HCCs that are predictive of low spending are just really poorly captured, or maybe the HCC infrastructure doesn't capture those codes. And so if instead we use individual ICD codes that were more expansive, would that minimize the difference between Franklin and the existing CMS-HCC approach? So two-part question. Maybe you can take the first part if you need. I can repeat the second part. But the first question was, why is it that the ML model, why is Franklin doing better on the lower spending side as opposed to, say, the higher spending side of the distribution?
Yeah, thanks. So as you mentioned, well, this is a clear observation, right? Franklin does much, much better than HCC on the low end of the distribution and slightly better than HCC at the high end. There are two reasons for that. One reason is that HCC does especially poorly at the low end. HCC captures chronic conditions and then acute serious conditions, but it doesn't capture the drivers of costs for those kind of low spenders. So if someone has a persistent recurring UTI, if someone has lower back pain issues, these are reliably predictors of kind of low acuity utilization in the following year, but are not captured by HCC. And these are things that Franklin can capture. These are obviously simplistic, kind of single diagnostic examples. And as I mentioned, Franklin kind of takes the full diagnostic profile of a Benny into account, but that's the reason on the low end. On the high end, it's a weakness of the idea of predicting spend using diagnosis only. And so if we go back to the folks that have no HCCs at all, some of them, for random reasons or because their health rapidly deteriorated over the next year or because some other reason, are going to experience an inpatient admission and sometimes a post-acute episode. And that is very, very expensive. But that's not captured in their diagnostic profile, right? Their diagnoses are not even enough to predict significant cost. And so we can't predict based on diagnosis alone which beneficiaries are going to be very high cost because that's primarily driven by inpatient admissions. And so there's just, in this particular data, which CMS uses by statute, there's no way of reliably capturing high cost beneficiaries. The second question, yeah, if you could repeat, Amal, I see Bruce's question in the chat, but you had a slightly different take on it.
Yeah, I guess my question there is perhaps related, but maybe not identical, which is if we, instead of using the HCC grouping that's coming through, and instead we just use all ICD-10 codes without any kind of mapping or filtering that I believe is happening in the HCC structure, would we then get better prediction from the native regression-based model that CMS is using, and would that mitigate the difference basically between Franklin? I know this is asking you to speculate because you haven't done the study, but I'm just kind of curious. What do you think?
So I have done this study and I can answer the question.
Excellent.
Okay. So first I'll answer Bruce's question, or a very specific one. Only about 6% of beneficiaries don't have any claims and therefore no ICDs. And so the difference is not driven by those folks. If we think about what would happen if we just threw all ICD codes into a regression model instead of rolling them up into a coarse-grained hierarchy like HCC, well, there are about 70,000 ICD codes. And if you do that, you're going to get a lot of noise. And so you can't just throw 70,000 variables into a regression. You need to be a little bit more careful statistically about how you do it. But you can build that model. And in fact, you do get better performance than HCC. That performance, so I think that the numbers were about 0.15 for HCC in terms of R square capturing the variability in cost, or rather relative cost, like how much more expensive percentage-wise a Benny is going to be. That gets you about halfway between HCC and Franklin. But Franklin, because it also captures the interactions between conditions, and because it's smart about identifying which conditions are related to each other in a way that's similar to the HCC hierarchy, but data-driven and not expert-driven, does capture, like, that gives you another doubling of the performance, essentially.
Great, thank you. Okay, Austin, I wanted to ask you a couple of questions as well, just so we can really hone in on the key points. So, so Ravi actually made a point that I thought might connect, and I was hoping you could help us connect it. So, Ravi pointed out that Black and brown beneficiaries may experience different spending, essentially, than other beneficiaries in the Medicare program. And that might be related to some of the issues around fairness in the model. And on the spend, if I understand your study correctly, so we're looking at social risk adjustment where you're now bringing in area level measures. So can you kind of help us understand what's happening there and how that social area level measure, social risk adjustment part may or may not relate to this point that Ravi's making about the differing effects or different care patterns and spending patterns of Black and brown beneficiaries?
That's a great question. I think that the area level measures are being used now partially to account for a lack of individual data on these social needs, and actually the risk adjustment models that CMS is allowed to use cannot actually specifically account for things like race and ethnicity, and that's a legal issue. So I think in some ways that the goal of this area level adjustment is to address a lack of individual level social needs data, as well as kind of get at kind of the predicted health outcomes for a small population. I think that being said, though, I think Karen brought up a very good point that there is data, that we have on things like frailty, cognitive impairment, other things that could be, at an individual level, rapidly implemented into an improved risk adjustment model. And I think I also want to point out that there's issues with the area level measures, which we're actively looking into. It's been reported, and I think it's fairly well established that the area deprivation index specifically may have some underprediction of outcomes for like rural areas versus urban areas. So there are some challenges that are kind of methodologically being addressed, and actually CMS is published on a new approach that they're using, something called the Community Deprivation Index, that tries to improve on the prior Area Deprivation Index, or ADI. I think there are, again, advantages to kind of an area level approach, disadvantages. I think it's worth noting that some of these individual social needs are dynamic, and requiring organizations to report individual level social needs data is also problematic. We've seen that any requirements to collect more data, like we've seen with Medicare Advantage, may kind of increase the opportunities for gaming. So again, I think there's we're balancing kind of feasibility, administrative burden, and accuracy in kind of this approach.
Great, thanks. So that being said, I wanted to follow up on one other point in your presentation. So we've seen kind of a variety of different outcomes that have been utilized in these studies. You chose in particular to contrast, as Ravi did to some extent, spending and mortality. And so I wanted to ask you about that choice. Like what is interesting about that? And especially as you're thinking about this in the context of social risk adjustment, we're using area level measures. And just to clarify for everybody, the area deprivation index nor the community deprivation index use race or ethnicity as a variable in their description of communities or neighborhoods. So, so I just wanted to clarify that point. So that being clarified, just can you give us a sense of why is mortality helpful relative to spending in this context?
Yeah, I think, Karen made this point very well, but spending, which is typically the outcome that we use to develop and refine risk adjustment models is very dependent on access and utilization. And we've seen, from Ravi shown that the access is in healthcare utilizations is less for certain populations. And so I think that the point of risk adjustment is to modify payments. So we have to look at spending, but I think it's also important to try to again, borrowing from Karen's slides here, but to decouple the spending from clinical risk prediction. So can we somehow target how we change our payments or account for clinical risk based on other outcomes like mortality, hospitalizations that are more true and less dependent on the confounded aspects of utilization. So I don't think we found exactly the right balance. I think you have to look at both the clinical outcomes and the spending outcomes. So setting that right target, I don't think we clearly have an answer, but you have to kind of consider both when you're evaluating these models.
Yeah, thanks, Austin. So Karen, you had a number of great reflections, and one of the points is the point that Austin made, which is this notion or concept of risk as spending risk is likely very different than clinical risk or risk of a bad clinical outcome. And yet it's a pretty vexing problem to think about how then to, like, what should we be doing? Because on one hand, if you think about this from the perspective of risk adjusting benchmarks in Medicare Advantage, risk adjusting benchmarks in value-based models like the accountable care organization models or other value-based payment models, in some sense, and this is a question for everybody, but we can start with Karen because I think it's not an easy one, does that mean we should be using the spending allocation one or should we be using the clinical one? Like I think it's hard, it's challenging. How do we think about that? How would you think about this, or how do we take some steps in that direction?
Well, I think in this day and age of data, we don't need to use the same model for everything. Right now, we don't exactly. We use the same components in the model, but the actual betas associated with different things do differ, and I think that's appropriate. If you think about, for social risk, for example, how does social risk impact outcomes? And I should pause and say, at this political moment in time where we are, there are a lot of sensitivities around how we can and can't talk about social risk and race and all of these things. And we need to be able to both acknowledge that and find a path forward that's durable. And I think, collectively, we can recognize that we can get a little bit more precise about how social risk impacts both spending and outcomes, and just saying it's, poverty is bad. Yes, we know this, but how and why, and how can we make the models sort of reflect our understanding? So one reason that I'm an advocate for including things that are related to frailty and essentially disease severity in the models is because that is to some degree how social risk drives outcomes. There is some independent risk associated with social risk, right? Living in poverty creates a certain amount of stress that is independently bad for you, but that acts through making things worse. So it's not just hypertension, but it's frequently uncontrolled hypertension. It's not just heart failure, but it's heart failure with 6 admissions this year. It's not just diabetes, but it's diabetes with multiple amputations. And HCC tries to do that a little bit, but because of the limitations and interactions, it just can't capture that multiplicative risk that comes along with true, deep social risk, which is really what we're talking about. The way that these things work, they tend to sort of be they're nonlinear, right? A little bit of social risk is not the same as a whole lot of compounded lifetime social risk, and that's where we really mispredict. So if you can get models that are more holistic and more getting at that frailty, functional status, cognitive status, all those things, you actually pick up a lot of like how social risk is making people sicker. And then I don't think you need to make a choice about doing it differently per se. You can let the models tell you what that is. But to me, the key thing is just taking into account that we need to better capture that more, sort of what Daniel said, that real like complexity of severity is usually where social risk acts. Now, you're never going to get around the underdiagnosis thing. For example, one reason that we see this mix of spending and mortality being different, think about something like dementia. So Black individuals are much more likely to be diagnosed later, which leads to a different set of options around how you might care for somebody, right? That's going to be the same for a lot of conditions. That's not okay. We can't correct all that through our payment models. We can expose it through our payment models. We can, or not through our payment models. We can expose it through our risk adjustment models. We can work to try to make these things better while also acknowledging that year upon year, these patterns exist sort of as such, and we should account for them.
Yeah, so great points. I think one of the things that I find challenging here is, and I think you may have actually done some work in this space, Karen, is, even if we take a broad set of data, a population, a sample, nationally representative sample of people, and we add additional data elements that are describing people, characteristics of individuals who might be at greater social disadvantage. This may be an area level measure, it may be an individual level measure. When we look at things like spending, however, it doesn't necessarily, one might think, okay, this makes great sense. Let's add this additional individual characteristic, but it's anything but guaranteed that that characteristic may actually lead to a richer prediction, let's call it, or higher prediction of spending for that individual. And I think, Karen, you have a study that looked at that in the context of Medicare Advantage. Is that am I characterizing that correctly, or maybe you can recap that?
Yeah, so in a Medicare Advantage sample, we found that higher area level risk at the tail was associated with lower than expected spending, presumably because of access. But it was at a tail of the distribution where I think we do poorly in accounting for all the other risks. So the interaction between individual poverty and access to care is also nonlinear. And I think most people probably access enough care to be reasonably well captured, but there is this tail, and it is largely occupied by people who are in sort of deeply disadvantaged social areas where there is no access. And so you end up with less predictable spending because you have less information about people, and then they have a catastrophic event. So it's you don't actually have the information about them, and then the event is worse because of that lack of access. But it's not that those people don't use healthcare, it's that it's used differentially. So more emergency department spending, more inpatient spending for the same condition. The math of that is like way above my head, but it's not above the head of like the models that are smarter than us, right? To be able to take those complexities into account. So I trust Daniel's models to do better than we as clinicians have done in naming what to actually put in models.
So a perfect segue. So I wanted to ask this question of Daniel and then Ravi, because I think it's relevant to both of your studies. So Daniel, I think one of the implications that Karen has pointed out, and I think several folks actually in the chat as well have pointed out, is maybe this is just about getting better data in the models. Karen has suggested some factors that are individual that are likely indicators of various types of non-clinical risks that influence clinical outcomes. There might be other ways to cull better data from other sources as well. So I'm curious to get your sense, one, is that feasible? You mentioned in your comments that, look, we can't just throw in 100,000 variables into a regression. So in that case, is ML the answer, machine learning the answer? Because maybe we can throw in 100,000 variables. And so I'm curious if you can kind of reflect on this point of, is better data the answer? And if so, are machine learning the methods the vehicle for us to get there?
Yeah, thanks. So the way we approached Franklin was to try to build a model that's entirely apples to apples with HCC, and so uses the exact same data features and data sources to predict the exact same thing. In that sense, we constrained ourselves to only using ICD codes, and it was clear that even with that data source, which is limited, we should be able to do much better than HCC. And Amol, you alluded to kind of what's the first step? Well, let's throw in more variables, and then we need to be a little bit more careful about how we distinguish signal from noise and so on and so forth. And there's a lot of technical work that went into Franklin, but I would say that that all falls under what we might call kind of standard machine learning approaches, that a competent data science or machine learning team in a health tech startup, given sufficient data, should be able to build models that are, pretty good. I think it's clear that diagnoses in and of themselves are not sufficient, at least to predict costs to the extent that that's what we're trying to do. And there have been ideas floating around. So Karen mentioned a few specific variables that you could add. Both Austin and Karen alluded to, well, let's add social determinants of health. Even if we restrict ourselves just to claims, there's a lot of data in claims about actual utilization. We could also think about Part D claims, so prescription and pharmacy data. Those raise concerns about, well, you don't want to inadvertently incentivize overutilization because of its impact on risk adjustment, but that would probably lead to more accurate risk adjustment, at least in the sense of more accurate cost prediction. And so I think that a theme of all three works here is that a risk adjustment model is part of a broader ecosystem and part of a broader payment system, and all the incentives need to be considered in that context. But yes, we can do much better with more data sources, and the way to do that is not a simple regression, but as Karen mentioned, we're technologically in a very different place than we were 20 years ago when HCC was implemented, and we should take advantage of that.
Great. So fantastic. Ravi, if you have any reflections on that, would love those. The other piece that I'll ask you also to reflect upon is, there's a comment in the chat also about, hey, can we use AI as a way to improve risk adjustment? The obvious concern that comes back right away is, well, are those models black box, right? Do we really know what's going on? And are there going to be potentially massive unintended effects? So we gain something for sure based on what Daniel was saying, but what is that trade-off, and do we even know what that trade-off is? Ravi, do you have any thoughts you can answer? Any thoughts you can offer on that, as well as what Daniel was saying as well?
Sure. Yeah. I mean, I think Daniel really put it well in terms of the potential impacts of adding relevant variables. I have sort of like one meta level caution about the type of extra variables that we would add, and one sort of potential algorithmic related caution. So one is that I think if we don't think carefully about like how we collect the relevant data that we're thinking about adding, then it's likely that some of these variable additions that we're talking about probably aren't going to do what we think they are. We've done some work in the VA which actually has pretty robust collection of individual level social factor data. But when we kind of just take the approach of plug everything into the model and see what happens, we actually don't see a lot of rectification of unfairness that we expose in things like predicting rates of hospitalizations to guide care management programs. And one of those reasons might be because the VA is sort of like a segmented population in and of itself. But the other reason might be when we're not sort of approaching what social variables we collect, whether that be at an area level or whether it be at an individual level, somewhat intentionally, thinking about, okay, which factors are likely to actually result in unfairness in the outcome that we're looking at, then we might not get the type of prediction that we think about, because some variables might be underpredictive of spending, some variables might be overpredictive of spending, and when you plug them in without accounting for what factors together, or perhaps in interaction with certain comorbidities, actually result in the unfairness that you're looking for, then you might just not get the result that you're looking for. Not to mention the fact that on the individual level space, we sort of run into the same problem sometimes with the problem that we run into with the condition level space, which is that we usually have better survey data for non-Hispanic white individuals than we do for Black and brown individuals. And so if we're trying to model relationships based on that, we might not be capturing the input-output relationships that we hope to. At a more meta level, I think that no matter how many variables we plug into the model to get a more accurate cost prediction, I still think we need to wrestle with this factor of, are we using risk adjustment to only predict cost, or are we using it to do something else? Are we using it to rectify, social certain biases that we just feel like are wrong in the way that we pay health systems and payers? And if we take the latter approach, then I think the problem just still comes down to predicting a biased outcome with spending, even using more accurate X's, predicting a really biased Y. And I worry that if we don't fix the Y problem, then the X's problem might not do much.
So I want to come back to this point of ML AI use in a couple of ways. So Daniel, I want to ask you for your thoughts on this notion of coding intensity differences between fee-for-service and Medicare Advantage, whether AI type methods can help on that side. And then Karen, subsequent to Daniel, I want to come to you and get your sense of receptivity for policymakers to use these type of models. They might do better. I think Daniel has been pretty convincing that the Franklin model does better, at least on one big part of the distribution. That doesn't necessarily mean that policymakers are immediately going to adopt them. So, Daniel, does this have anything to do with this concept of defensive AI, or can we set up these models in a way that aren't gameable or that protect against this kind of coding intensity differences piece?
Yeah, so it's a great question. We think that Franklin itself is more robust to gaming than HCC. For the simple reason that the contribution of each ICD is not deterministic, but it depends on all the other ICDs that a particular beneficiary has. That said, we understand that we're talking about fairly sophisticated players here, and the plans that have a higher tendency to upcode will probably try to find ways to game the system regardless. And so that does raise the question of, okay, are there robust methods or defensible methods that can either identify gaming or maybe even counteract gaming? I'd say this is very much at the kind of forefront of machine learning research, right? And so we actually have some work that we're doing in that area. I think that in terms of identifying gaming, this is a goal that is, I'd say, probably within reach using machine learning and AI. The question of how CMS or other agencies might use that, I'll leave that to Karen.
Karen,
Yeah, I think
thoughts?
there's a couple interesting sort of wrinkles here. So one is we talk a lot about upcoding, but the reason it's a problem is because MA is, well, there's many reasons it's a problem. One particular reason it's a problem is because MA is anchored to fee for service in this space, right? So if you upcode an MA, you're getting the benefit of relationships that are established in fee for service. So the model doesn't automatically start down valuing something that gets upcoded, which is quite feasible, right? If you're leveling across the population that you're paying, as more and more people code it, it becomes worth less and less. But you can't do that if you're anchored to a different population, which doesn't make any sense to me and is I think a policy change that can be made. We also know there's undercoding in fee for service. So we did some stuff when the first Medicare Advantage encounter data came out, looking at pharmacy data and both fee for service and MA encounters. And there were a lot more fee for service patients who were taking insulin who had no code for diabetes. And there were a lot more Medicare Advantage patients with diabetes who had no medications for diabetes. Neither of those is correct. You can certainly have some diet-controlled diabetes. I can't think of any reason you should be getting insulin if you don't have diabetes. You can't anchor on these two spaces that have such different coding norms and think that that's going to work. So that's a policy problem. I think the idea of whether or not you can have black box models, historically, CMS has said no. We need to know exactly what's going in it because payers need to know exactly what's going in it. But that's a lobbying question, not a policy question. From a policy standpoint, there's no reason that needs to be the case. It's purely a lobbying question because the MA plans want to know what goes in it because they want to be able to game the system. But you could decide as a policymaker that we're going to have a risk model that is directionally explainable without having explicit, deterministic numbers tied to each thing, and still, I think, be legally defensible and, sort of withstand all concerns in that space. You just have to make the political decision, which is different than a policy decision, around where you're willing to draw that line. Total black box model, no. But a model where you understand the inputs and you have directional understanding of what things do, I think should be in play.
Thanks. So that's super helpful to create some differentiation there on the kind of policy versus lobbying and other aspects of the multi-stakeholder environment, which our Medicare program lives in. So that was a tough question, and maybe I saved the toughest question for last, and for you, Austin. So Emma from our audience asked a really fantastic question. I'm going to paraphrase. She said there's a study by Basu et al. That showed average practice needs are $66 PMPM to meet social needs. That's not what social risk adjustment and ACO REACH or likely team or any of the other models that have this notion of area level adjustments are providing. What is your sense? This is kind of a vexing policy question. What is your sense of how we titrate that social risk adjustment amount? Like, how do we make that work? The existing programs, to my knowledge, are essentially budget neutral about this. So they're sort of shifting from areas or bennies who are in areas with very low social need, at the extreme end of low social need, and then kind of transferring it over to those bennies that have higher social need. How do we think about the magnitude? What's the right way to think about this? Is there a right answer? Kind of curious to get just some your thoughts on that, and then after that, we're going to wrap up.
No, there's no right answer. I think it begs a larger question of, what exactly are we trying to do with like these payments? Is this an additional investment? Is it best served channeled through healthcare and health, or do we consider, what are the consequences for investing in the social system? I think, the increased payments that we might be providing with this method, they aren't enough to actually intervene on the underlying social determinant. And I think that's important. I think what we're trying to do is level the playing field for the safety net providers that care for these institutions to be able to implement care improvement activities that we know will disproportionately improve care for individuals with social needs. And so I think that's the target. What does a safety net institution, hospital, ACO, whatever that case may be, need to provide that greater level of care and allow it to kind of improve the outcomes of the beneficiaries it serves. So, and that's kind of a non-answer, but I think we do really need to think about the on-the-ground improvements that these organizations are making to help titrate what that actual dollar improvement might be.
Great, thanks, Austin. So thank you so much, panel, for a really lovely discussion, a number of great empirical studies, I think, that have given us a glimpse of areas of opportunity and risk adjustment, as well as potential future developments that are going forward. Quick recap I would give here is there might be some short-term wins. Karen did a nice job of outlining them. So maybe we can add additional variables that are already in the data that we use that might be good markers for subgroups that we might care a lot about. It seems that really paying attention to what we're predicting and why we're using that predictor, there might be reasons to predict different outcomes other than always spending, and think about using that. And then Austin has done a nice job of outlining areas where area level social risk adjustment might really add to what we're trying to accomplish, which is really about resourcing provider groups appropriately for the populations that they care for. So with that recap, I wanted to thank the audience for participating, for submitting lots of questions. A special thanks, of course, to Ravi, Daniel, Austin, and Karen for dedicating the time and also sharing their insights and their empirical work with us. Thank you to the Commonwealth Fund, Robert Wood Johnson Foundation, and Smith Futures for their funding support to make this work, these projects, and this webinar happen. And thank you very much to the Perelman School of Medicine, Media and Technology staff for helping us pull this webinar off. So thank you so much. We appreciate all the interaction, and hopefully everybody got a glimpse of what risk adjustment in the future could look like. Thank you so much.